Good morning, everyone. Good morning. All right, fantastic. It's a great day here at Missouri Southern. Thank you for being here for the second day of the Willcoxon Innovation in Health Sciences Summit. This is, of course, the inaugural summit. We're very grateful for the support of Dr. Bob and Willcoxon to make all of this possible. We had a great day yesterday, including breaking ground on the new Roy Blunt Health Science Innovation Center. So it's an exciting time, not only in Missouri Southern, but in our community. I also want to thank everyone for being here. It's great to see this morning partners from Freeman, from Mercy, from Kansas City University, people from the community, faculty, and it's always wonderful to see so many of our students here. So thanks for being here. We are really honored this morning to have our keynote speaker join us, Dr. Christa Martin. And I think it's very appropriate that we bring in someone of her experience and stature to serve as our keynote for this inaugural summit. And I'd like to tell you a little bit about Dr. Christa Martin. Dr. Martin is the Chief Scientific Officer at Geisinger. She's also Vice Dean for Research at Geisinger Commonwealth School of Medicine and Professor and Founding Director of Geisinger's Autism and Developmental Medicine Institute. In terms of academic background, Dr. Martin received her bachelor's degree from Penn State University and her doctorate PhD in human genetics from the University of Pittsburgh. She did her clinical and research postdoctoral training at the University of Chicago and remained on faculty there as an assistant professor and director of the Clinical Cytogenetics Laboratory in the Department of Human Genetics. And before joining Geisinger, she was an associate professor in the Department of Human Genetics at Emory University and senior cytogenetics laboratory director and operations director of Emory Genetics Laboratory. She has been funded continually by the National Institutes of Health for over 25 years and authored more than 170 publications. Beyond that, I can tell you she has embraced Joplin and taken the time to be here for 3 days and learn more about our community and our efforts to work together to advance the health sciences in the region. So it's my pleasure to welcome to the podium Dr. Christa Martin. Please give her a Joplin and Missouri Southern welcome.
Yesterday. Thank you. Good morning, everybody. I always forget how complicated genetics terminology sounds when you're talking to other people. It's really just chromosomes is what I've done for a long time. So I really am just so pleased to be here to share this exciting inaugural Willcoxon conference with everybody. I had a wonderful time meeting people yesterday, seeing the enthusiasm, hearing the enthusiasm of the students and the faculty and staff, community leaders and healthcare leaders. Really just so excited to see this initiative get off the ground and continue. And so today, I feel like everybody in this room, from what I've learned, has an opportunity to be a part of this exciting journey through the future. And I want to thank Dr. Van Galen for inviting me to be here, as well as others. From the first time we talked on Zoom, we had a connection, I think, and we felt like there were so many similarities between what is being built here and some of the work that's been done at Geisinger over the years. And so today I'm going to share that with you in hopes that you can see similarities and have a vision for the future. I also wanted to thank the Willcoxon family for their support. It was a joy getting to meet some of those family members yesterday and talk to them and just hear how excited they are about the opportunities that exist. And I don't have any personal disclosures. So as I said, we feel like there were a lot of similarities, and I wanted to go way back to the beginning of Geisinger. So Geisinger is a health system in Pennsylvania that was founded by the woman shown on the screen, Abigail Geisinger. So at 85 years old, this woman decided that she was going to start a healthcare system. This car, it's called a Hupmobile, was left to her by her late husband, and in the community, there was not a nearby hospital. And so people continued to ask her, can you drive me to the hospital? Can you drive me to the hospital? And she said, you know what? I'm going to start my own hospital so I don't have to continue to drive people to the next town over. And so at 85, she set out to recruit Dr. Harold Foss as the first chief of staff. He was trained at Mayo, and so a lot of what we do at Geisinger today is actually based on that Mayo model of building a rural community healthcare setting, taking very good care of patients, and going to where they are to provide the very best care. And at her groundbreaking, and I find this quite amazing, at the age of 85, single female, decided, I'm going to bury a time capsule, and I'm going to leave instructions that say, don't open this time capsule until 100 years. So already saying, my hospital is not only going to be established, but it's going to survive 100 years and be successful. And I'll share with you that we just celebrated our 100-year anniversary a few years ago. So the hospital was established in 1915. We opened up that time capsule. It was interesting, all of the things that were in it, money, different ways of looking at healthcare data, some of the early records of patients. We planted a capsule for the next 100 years, but it's really just an amazing story of a single woman in a rural area who started a healthcare system that now serves over 800,000 patients across the state of Pennsylvania. So this was Geisinger then. This is our Danville campus, which is our main hub for our healthcare system, and this was in 1927, and Abigail coined the phrase to make it the best, and that still is a motto within our health system. But this is Danville today, so you can see our campus has grown, and this is in 2024, and our current vision is making better health easier. So that's for our patients, for our staff, for our communities. How can we bring healthcare to them and make it easier for them to be healthy? So I know many of you may not be familiar with the geography of Pennsylvania, so I always find it helpful to just explain briefly where we are and the area that we cover. So on this map, it shows Geisinger's service area, which I've heard described as there's Philadelphia on the east side of the state, there's Pittsburgh on the west side of the state, and sorry for people from Alabama, but there's Alabama in between, which means the rest is a very rural area and very sprawling. So we cover a large portion of central and northeastern Pennsylvania. Our primary service area is shown in darker blue, secondary and where we're continuing to grow in lighter blue. And we actually have our own health plan that's not required to be used by patients, but is used by a large proportion of our patients. And that's now has expanded through Medicare across the entire state. So we care for patients across the entire state of Pennsylvania or cover them with our insurance plan. So our service area actually covers close to 2 million patients. But as you can see, the cities that our hospitals and our health centers are in are actually rather small, similar to the size of Joplin. So our Scranton area, which many people are probably familiar with the office or where President Biden lives, is Scranton, is about 75,000 people. Wilkes-Barre is another about 44,000 people, and Danville, which is where we started, only has 4,000 individuals in our community. They call this densely rural, so a lot of pockets where there are people concentrated, but overall it's a rural area. And as I mentioned, we now serve more than 800,000 patients across this region. Overlaid with our service area is our College of Health Sciences. So this includes our education and research opportunities. And here, I think I lost one of the, let me see if I can show you. So up at the very top right is where our School of Medicine is. So our education facilities are actually also distributed across this large region. So our School of Medicine is in the top right. We have a School of Nursing that's sort of in the middle of the state. We offer master's programs. We have residency and fellowship programs. And we also, of course, support the faculty who teach all of our students. And we recently launched, similar to you, a new vision for our next 5 years, which is called our Drive to Thrive strategic plan, where we're aligning our goals for research, education, and the clinical work that we do with our overall system goals. And Thrive means to transform health through research, inspiration, value, and education. And there on the right, you can see our med students making a G to show how excited they are about our new strategic plan. And so in line with our vision of our overall system, really the college's goal is to make better health easier at Geisinger and beyond. So we're thinking big like Joplin. We want people to recognize us on a national level for the work that we do and the innovation that we have. Through the education, research, and scholarship that develop healthcare professionals, inspired and prepared to improve the health of diverse people and populations, and to use Geisinger's unique assets to transform the way care is provided. And we do this in an integrated healthcare organization, meaning we have clinicians, we have insurers, we have educators, we have scholars that support academic excellence, attract the very best, and ensure the ability to thrive in a sustainable and inclusive culture. And so we were excited to kick this off. And I'm excited to share some of the innovative programs that we've developed today in hopes that it can inspire you to think about how you as a community can lead and not follow by really strategically aligning the goals across initiatives. And from what I learned yesterday, there are a lot of different groups coming together here that have great opportunities to look for where they can leverage strengths and work together. So just briefly, to give an overview at a high level of Geisinger, as I mentioned, we now care for over 800,000 patients. We have 10 hospital campuses that span rural Pennsylvania, 133 primary and specialty clinics, and we have more than 25 employees, including more than 1,700 physicians. We also, as I mentioned, have our own healthcare coverage, so we manage over 600,000 lives in that plan. We're contracted with providers across our network, as well as hospitals across the state. And then my background and where I'm most involved at Geisinger is in research and education and innovation. Our med school has about 115 students per class, so we now have over 600 students as well as master's students at our College of Medicine. We have a nursing school that we just recently started an associate's program, and we have nursing students who come to work with us and train with us throughout our region. We also have residency and fellowship programs, which includes over 600 trainees in these areas. And then for our research group, we've really put an emphasis on trying to garner external funding, either through federal funding or other resources to help support the work that we do and be able to include trainees in the research that we're doing as well. And that results in a number of research projects, including clinical trials, where people can get exposed to that type of research. And then I think importantly, we partner with our communities. So we're in a rural area, just as Joplin is, and we struggle to keep the amount of physicians and nurses and other healthcare providers that help us to take care of our patients. So we've really put a lot of emphasis on trying to work with our communities to build these types of pathway programs so that we can expose children. We've moved our timeline back to middle school to start exposing them to what a career in healthcare looks like. And that could be clinical or non-clinical work, but giving them the resources that they need, having programs to get them to learn more about what we do every day. And we now have over 5,100 students that have been trained in a number of our pathway programs. We partner very closely with our community agencies, hospitals, or other healthcare organizations. I mentioned we go down to middle school now, but also have very active programs with our high schools and higher education institutes, really to make a plan for the future, to make sure we can serve the patients who need our help the most. And all of this really comes together in the vision of what we call a learning health system. So as we take care of patients, as we do our routine jobs, we can think about how do we educate others, how do we expose them to doing the best job that we can do, how do we innovate together, and how do we do research to discover and learn more every day. So we bring this together, combining our education and research programs, our health plan programs, and all of our clinical areas that are shown in this slide in order to build this learning healthcare system where we're learning from what we do every day in hopes that we can take better care of our patients and the populations that we serve. And so as I reflected on some of our conversations and information that I read about the Joplin region, there really are a lot of similarities between where Geisinger is and the Joplin region. So it's great to see when people come together in partnerships and try to work together instead of compete. There's always going to be competition, but there always should be ways to work together as well. And so having partnerships across different organizations and geographies, I think, helps to lead to success in building visions together. It's also important to have a community emphasis, and I think that was just clear yesterday from my experience here, that there is a sense of strong community and vision to work together. I mentioned the rural area that is similar between us, but also the demographics of the population served. So similar to Joplin, Geisinger has an aging population, and I'll talk about one of our programs that focuses particularly on individuals who are 65 and older. Again, trying to look for unique opportunities where we can differentiate the type of care that we do and how we take care of our patient population. And then really just by bringing medical, education, research, and other groups together to not only serve our communities better, but also fuel the future of healthcare. So I'm going to go through a few ideas of how we lead and don't follow. The first being designing innovative programs that leverage unique strengths. And we had several conversations about that yesterday. With Geisinger, I think some of the strengths that we've really leaned into is in the data that we collect every day as part of patient care. So you don't think when you go to the doctor, how much data is being collected from the lab tests that you have done to your weight, to your height, to whether you smoke or if you're on statins. All of that information can be used, if structured appropriately, to ask questions about how we can take better care of patients. So that's one strength that Geisinger has leaned into. And then you heard mentioned this morning, genomics is another. So how do we layer our DNA information on top of our health information to try and figure out how to provide personalized medicine to the patients that we take care of so that we're not treating everybody the same. We know we're not all the same. People have different risks for different diseases, and so trying to take care of each individual patient using that personalized genetic information. So this timeline just shows some of the innovation that we've done more recently over the last 30 so years. I told you that Geisinger has existed for 100 years, and certainly research, education were part of that process, but it's really been in the last several years that we've escalated the work that we've done. I think another parallel that we discussed yesterday, in the last 10 years, we've done a lot of the work with our genomics program that I'll talk about. And so 10 years sometimes seems like a long time, but it really isn't that long. And so the fact that you're all talking about this initiative and vision, before you know it, 10 years will be up and it'll be exciting to see what you've accomplished. So we established a large center for research in 1985 and also opened a children's hospital. Importantly, we were an early adapter of electronic medical records. So I'm sure many of the students in the room are learning about electronic medical records, documentation, and we have been on the same EPIC system since 1995. And so that has afforded us with a measurable amount of longitudinal data to really ask health questions about natural history of disease, how do disease and patients respond to treatment, et cetera. We launched Proven Care, and this is another one of the sort of Geisingerized programs that really is built on taking better care of patients, but by treating patients with the same types of processes using evidence-based medicine. So if somebody's having knee surgery, it makes sure that everybody does the knee surgery the same way, unless there are differences that occurred during that surgery. But it's really to try and elevate the level of care that's given in a standardized way across our system and improving the quality over cost, which I'll talk about in more detail in a little bit too. Our MyCode Community Initiative was launched in 2007. That's our large genomics program. I mentioned that we integrated a school of medicine to the overlay of our system, and I'll talk about some of the unique education programs that we've started there, including the Abigail Scholars Program, which is a program to provide scholarships to our medical students, and you can see our namesake Abigail. Those are named after. And then 65 Forward, our health centers that we launched specifically to try to take care of our aging population, and I'll give you a little bit more information about those too. So Geisinger didn't always have a medical school. There was a medical school that was started by the community called the Commonwealth School of Medicine, and it wasn't until 2017 that that medical school was integrated into our system. We saw it as an opportunity to really grow our own physician workforce, and so the programs that were built and the training that's given is specific to our rural area. We try to have a certain percentage of students in our classes that are from Pennsylvania. We hope that they want to stay in Pennsylvania. We have currently 464 medical students in our school, and of those, 174 are Abigail Scholars, which means they are on full scholarship to come to school at Geisinger with the anticipation that they will then come back to Geisinger after their additional training, either residencies and or fellowships, and serve as physicians at Geisinger for a certain number of years. We're just building our alumni organization, but many of them also, so about 35% are practicing or doing additional training in Pennsylvania. So we're really trying to train individuals to be a resource for taking care of our communities well into the future. And as you can see, we have partnerships with many of the local health systems that exist with us, largely to help to train our medical students. And so we work very closely with AtlantiCare and Guthrie, which are other large health systems near our region. I mentioned the Abigail Scholars Program. I think this is a really unique, innovative way to offer training for physicians to help build our physician workforce. It's a substantial investment, but one that we all think is worth it. It's based on a forgivable loan program, as I mentioned, with an obligation to return to Geisinger. They have a 4-year repayment, so they work at Geisinger for 4 years as physicians and our colleagues. We hope that after that time they want to stay and remain and be our colleagues, but at that time they don't have to anymore. We enroll people in this program based on their scholarly achievements, but also as part of being in the program, we look for where we're going to have gaps in the future as part of healthcare services. And right now, those are in the areas of primary care and psychiatry. So if you're in that program, those are areas that you would need to specialize in order to qualify for those scholarships. And we're building enhanced curriculum in health system science, really again to give these future physicians tools to ask research questions and be involved in discovery as they take care of patients. And importantly, we're always trying to show the value that we provide back to our overall system. And so Geisinger uses this enterprise scorecard system to measure success. And we've recently included learner to employee conversion as part of our metrics for how we are contributing to the growth of Geisinger and our workforce. We don't only do this for medical students, we do it for nursing students as well, and really have seen success in keeping people after training in our system, which is really important. As I mentioned, I think it's important to think about the strengths that you can lean into. And from a research perspective, we've looked at the opportunities that we have at Geisinger to really excel and differentiate the work that we do and serve as a national model. I mentioned that we've identified data science and informatics and genomic health as key areas, but also on a broader scale, population health sciences and how do we take better care of our population, really to keep them healthy rather than treating them when they get sick. We have a lot of our patients that struggle with obesity and metabolic disorders as a result. And so because of that, we focus a lot of our research on how do we help them through these issues that they have. And then we have a lot of focus on just in general community environment and health and how can we provide our patients with the information that they need to live a healthier lifestyle. I mentioned that we've built a huge data warehouse over the last 20 plus years. Again, this is information that is, it's not totally free, but it is free if you're collecting it from routine care and then using it to learn more as we go. We've amassed 4 billion records in a data warehouse that include 350 million encounters from our electronic health record, amassing data from over 2 million patients, lab results, et cetera, and building this warehouse that makes it easily accessible for people to use to learn as we go. And now, as I said, we've layered on top of that DNA sequence information, which provides the next level of information for looking at healthcare opportunities. And so where we've taken strategies with research to hopefully optimize the work that we do is to really lean into our strengths. So the data, the stable and trusting population. And again, being in a rural community, you really do have a population that wants to help you do the best that you can. We find that we have higher consent rates, for example, for our research studies. Patients want to help their community members. They want to help us discover new ways to treat diseases. And so being innovative in the way that you engage them and work with them is really important. In our rural area, we actually have a very low out-migration rate. So less than 1% of the people in our area move somewhere else. Now that's shifting a little bit, but people are born in our hospitals, they live their lives and at some point die in our hospitals. And so there is this allegiance and a very community-driven initiatives to really try to take care of each other. And I see that and have heard that from being here the last couple of days. We've also taken the approach of not doing so much basic science. Basic science is really important to learn, but in a healthcare system, we've tried to do more applied research and things that we can see a direct line of sight that will be important to our patients and how we take care of them and hopefully keep them healthier. And so we do more population-focused research. We do implementation-based research. So we do things right in the clinic. We're running trials in the clinic. We're trying new things in the clinic. But importantly, we're keeping track of what we do. We're measuring it, and we're comparing what we do in that group to people who don't get that same type of treatment, and in order to see what works and what doesn't. We also are matching faculty expertise with system initiatives. So we strategically have been recruiting and building our research and education faculty to meet and match many of the goals that we have, and really supporting team science. So a lot of times you hear success is measured by individual investigators and how well they do. Well, it's hard to work as an individual when you have such strong team members around you. And so we really encourage teams to work together to be more successful than just having independent research. And then, as I've mentioned several times, I can't state enough how important partnerships are. And we've looked for partners in other higher education partnerships in our region with industry and others to build collaborations together that hopefully at some point will lead to bigger external funding opportunities, philanthropy, or NIH funding or other federal dollars. So I wanted to mention, given, at Missouri Southern, the work that you do and the other education institutes in the region, we also have partnered with several of the universities and colleges across Pennsylvania for research and education opportunities. So we offer pilot grants to bring people together to try and ask research questions that leverage the strengths of the unique groups that are working together, in hopes that they'll continue to work together, build scientific teams, train students as well in those projects, and then hopefully garner external funding. And these just are some of the groups that we work with, including Penn State and Bucknell University, Lehigh, Children's Hospital of Philadelphia, and Jefferson. We also think it's really important to expose students and learners to research opportunities. I show on this slide the number of medical students that we've involved in research programs, projects over the years, but I know that there's a strong nursing program here, and we've recently really started to engage nurses in research to show them the different options that are available to them as part of their career trajectory. And we think this is important so that, as you're taking care of patients, you're the ones who are on the front line doing the work every day who can see, this doesn't seem right, or I think I can do this better, or what if I tried this? And so providing people through their training the tools to really ask those questions, but then to have the resources behind them and the teams to work together to try and answer those. As I mentioned, research isn't free, education isn't free, and so we have to be creative in how we plan for, structure, and support the programs that we build. And at Geisinger, just over the last 13 years or so, we've substantially increased our external dollars to support the work that we do. So our hope is to decrease internal investments and garner more money from outside of our institution. And we've done this through a number of ways, including, I mentioned NIH funding, and other federal funding. So now about 58% of our external funding comes through federal awards. We work with industry partners, and I'll tell you a little bit about some of those in our work with our genomics programs. And then we receive some funding from the state and other organizations and from philanthropy. And then when we think about uniqueness in our clinical care, so we have a lot of discussions ongoing now. How do you take the best care of patients, or what works best for them? Where do patients want to be in their healthcare journeys, or where don't they want to be in their healthcare journeys? So most patients don't want to end up in the hospital. None of us do. So we've been doing a lot of thinking as how do you keep the patients close to home? So taking services to them, because when you do that, not only do you keep them in a more comfortable environment for them to have their healthcare needs met, but it also decreases costs. Once somebody comes to the emergency room or once somebody ends up in the hospital, we're spending a lot more dollars to take care of people. And so we're trying to be creative in how we take care to the home. And that includes a program called Geisinger at Home, where we have nurses and other healthcare providers who go into the home to provide people care. A lot of this are things like if somebody's undergoing cancer treatment, we might do their infusions in the home instead of doing those in the hospital setting, but ways that it makes healthcare easier for patients to be better taken care of. A lot of this falls into what many of you may have heard talked about more recently, value-based care. This is really just trying to increase the quality of care while you're decreasing costs, which we all love to figure out how to do that. But it really is thinking about how do care organizations, so insurers and physicians and providers, work together to try and build programs that take better care of patients. And a lot of this takes partnerships. We're lucky because we have our own health plan, although we don't require everybody to use our own health plan. So it allows us to look at different models for how we can really increase the success of taking better care of patients. And some examples of this are, having people work to the top of their license. We've done a lot of work in nursing recently where, if a nurse doesn't have to do that, can a nursing assistant or can a volunteer? We've used, innovative ways to make the nurses' jobs easier. So we know when people get discharged from the hospital, often there's a timely wait for them to get discharged. Well, now we use iPads, and we have some of our retired nurses who didn't really want to be retired. We brought them back and let them discharge people through an iPad while the nurses who are on service are doing other things that are more attentive to the patient's needs. And so thinking about ways like that where you're allowing providers to really work at the top of their license. I mentioned our proven care system. This is really trying to work towards systematic and evidence-based care and reduce unnecessary variation between patients, really trying to prevent at every level. So there's a shift to, we don't want people in the hospital, we don't want people to get sick, we don't want to have to treat them. Let's try and get upstream and see what clues can we use or what resources can we provide to keep patients healthy and prevent disease at every level rather than treating individuals once they get disease. And then, as I mentioned, just trying different modes of care management to ensure care delivery and looking, can you shift from those expensive venues to less expensive venues where patients really want to be? I've been talking about a lot of changes today, and there's changes upcoming in Joplin, and with all of your groups working together, we actually have a big change coming. So Geisinger was recently acquired by Kaiser Permanente, but this was a different type of acquisition where they're forming a new healthcare organization called Risant Health. So it's so new, they had to make up a new word. So Risant actually means continually rising, as I've been told, but it's to bring these like-minded healthcare systems together to really try and figure out how do we take better care of patients on a scalable way and take care of populations. So we're remaining Geisinger, we're not changing our name, but again, it's opportunities to think about the future and how do we optimize the way we take care of patients, the way we do research, and the way we educate our next generation of providers. And so I'm just gonna give you some examples of where we've been thinking about this and how another way to lead and not follow is really by seeing and preparing for the future, for looking for those opportunities where you have a unique niche or where you have strengths that you can bring together to make a difference. And one of those is by focusing on the populations that we serve. So I mentioned that we have a growing population of individuals who are 65 and older, and we really want to keep them happy and healthy. We want to be able to provide them with the resources that they need, to be in close contact with the clinicians that they work with. And so we've started having clinics that are specifically developed for patients who are 65 and older. So it's very senior-focused primary care and wellness program. They need to be on our health plan is the only caveat for that. But it really is meant to address unique health status and vulnerabilities to keep them healthy and happy. They're almost like community centers when you walk into these places. So they've become a hub for senior citizens to meet their friends, not only see their doctors, but they have exercise rooms, they have a coffee shop, they allow same-day appointments, so they make it very easy for these individuals to stay in close contact with their physicians. We all complain about you walk into your primary care visit and you get 15 minutes. These have longer visits, so 40 minutes to an hour, so that they can hear from the patients what's really going on and try to address their needs. Everything's under one roof, so they can get their labs drawn, they can have images done. And as I mentioned, we've tried to provide social and educational activities as well as personal wellness plans to really make this a sort of holistic approach to how they should think about keeping themselves healthy as they get older. And again, trying to catch clues for things that might not be right earlier rather than after they've developed to the point where we might not be able to treat them as well. This program now has over 9,000 participants. We have 11 sites, and we're in the process of adding more. And we have 23 physicians who are dedicated to these centers where they can provide those longer appointments and spend more time getting to know their patients. So just some of the examples where we've been able to see a difference in quality performance by using this type of a healthcare model. So on the top line, and this is just being compared against a national benchmark, you can see that A1C, which is a measure of diabetes, if you're greater than 9 on that, you are in poor control. And 17% is the benchmark for the national model. And with our 65 Forward program, we've been able to keep that much less at 7.2%. Another area where we've started to see a difference in was breast cancer screening. So it's much easier when you're seeing patients on a more frequent basis and building those relationships to make sure that they're appropriately getting screened for breast cancer. And there you can see a difference from 87% in these clinics to 77% as a national benchmark. Others are still similar, and we're hoping to see changes in the future, but this is just one way to sort of measure the success of these programs. The other is, are we successful at keeping these individuals out of the emergency rooms or out of hospitals? And so far, with the programs that we've started, we are seeing that the patients enrolled in this program have about a 40% lower ED visit rate, as well as a 15% lower hospitalization rate. And I think most importantly is the experience of the patients. And so we have a very high likelihood for patients who are enrolled in this project to be recommending enrollment to others. They feel like the staff work together to care for you, and a very high overall assessment. And so because of these results, that's why we're continuing to grow these programs as one of our major initiatives and areas of focus, given the populations that we serve. Again, trying to look for unique niches that really address the growing needs of our community. And then I'll just take the last few minutes to go over what I would say is our bigger focus area and the program that really has grown the most in the last 10 years. And that's our MyCode project. And this is adding, the DNA sequence, as I said, to our extensive medical record data bank, and really thinking about how do we leverage new technologies to build healthcare for the future. Sequencing used to be very expensive. You heard Senator Roy Blunt mention Francis Collins yesterday, the previous NIH director. When he first came in and took that seat as NIH director, it was millions of dollars to sequence one person. And now we're down to a few $100s. And so technology developments like that allow us to really change the way we think about how can we incorporate that, not only into research, but really that makes it realistic to be able to incorporate it into clinical care. It now costs less to sequence a person and do the interpretation than to get an MRI. And I still hear people saying, it's so expensive to do genetic testing as part of clinical care, and I say, it's less expensive than MRI. So we need to change how people think about some of those things, because using genetic information to help take better care of patients is really in a place where we can truly think about doing that now. And this was a vision that was seen in 2010 by the chief scientific office who was in this role previous to me, who really leveraged and thought about where we will be with DNA sequencing. And at that time, he said that DNA sequencing will become a routine part of public health and medicine to improve individual health and well-being while maintaining or reducing the cost of healthcare over the lifespan. And to do this, we need to demonstrate the clinical utility and value of genomic information at both the individual and population level, and said at that time that Geisinger is an ideal healthcare laboratory. So we sort of identified our one thing to focus on and have been building that program over the last 10 years to where we are today. And I always like to tell stories as I explain the impact that genetic information can have on our patient population. And so this story is of a 40-year-old woman who enrolled in our research program and was found to have a disease change in a disease-causing change in a gene that we know causes issues with the heart. So the gene that's called KCNQ1 is a potassium channel gene, usually keeps the heart beating at a normal rhythm, but if this gene isn't working right, it causes a form of arrhythmia called long QT syndrome. And this can actually result in sudden death. So you hear a lot of times about an athlete playing in a basketball game and they collapse. A lot of those individuals who are younger ages actually have genetic causes like this, that we can identify. And so we knew that this mother had this change. We actually found out that her mother died at a very young age in her sleep at the age of about 30. So we anticipate that that was likely the cause of her death. And this woman has 2 sons. And so we tested the 2 sons and found that they both carry the same genetic change consistent with this long QT syndrome. And so we have drugs that can treat this now or help to treat it. So there are beta blockers that we can give to these individuals. And the family also carries an automatic external defibrillator, which they can take to their boys' sporting events. And the quote at the bottom is from this mom that says, "I thank God for this program that this mutation was found and I'm not bearing one of my kids." So it has a huge impact on giving information to people, letting them know what their risks are, and then hopefully working with them that we can mitigate those risks and prevent disease. And so our Geisinger MyCode Community Health Initiative really takes this information and is trying to turn hypotheses into health. We're looking to try to make healthcare better. We partner very closely with our patients on this. We keep them engaged in this program. We work with communities and hope that the information that we learn through this can not only be important to our community, but really as genetics grows and becomes more and more a part of routine medicine, that we can give information and contribute information to people around the US and the world. We study a broad range of topics related to health and disease, and now we actually have more than 340,000 of our Geisinger patients who are enrolled in this research project. And we actually give every Geisinger patient, either through in-person consenting or consenting through their electronic record, the opportunity to participate in this initiative. And when people are asked, it's more than 70% of our patients say, yeah, I'd love to participate in that program. So it's population-based. We go and offer coverage across our Geisinger patient population. As I said, we have an engaged community and a high consent rate. We link the information from the DNA sequencing that we do to the clinical information in the EHR, as well as claims data, to try and take all of the information that we've amassed and use it to inform the research and other work that we do. We are in a very rural area, so we are pretty homogeneous as far as ancestry, and more than 95% of our patients that enroll in this project are of European ancestry. Tends to be more of an adult population, although we do enroll pediatric patients. And we have close to 14 years of longitudinal EHR data for patients. So again, just that rich resource that allows us to ask questions about health and disease. And it really spans the ages. So on the left is Loudon, who is our youngest enrollee. So his mom, Cheryl, and Loudon was actually enrolled at birth. And then on the right is Ruth. And I actually now need to check on Ruth because this slide we've been using for a few years, and she was over 100 when I last checked. But yeah, it's interesting. We have a lot of individuals who are over 100 in our cohort, which again, thinking about longevity, are there studies we can do using those individuals to see what choices did they make as part of their lifestyle that they're living, or what genetics do they have that they're living into their hundreds. I mentioned that we've had industry partnerships, and this program is one that we did partner with industry on to do the sequencing. Regeneron is a pharmaceutical company very interested in using genomic information to try and develop personalized and precision medicine approaches to therapies. And so we started our relationship with them back in 2014. We were featured in the New York Times as, a driving force to push genomics into healthcare. And we're one of the first healthcare systems, or the first healthcare system to really launch this large of a program. There are many now that have followed, and people are offering this type of sequencing, not only for research, but there's a lot of uses just in routine clinical care based on family history. If you have a strong family history of breast cancer that's seen in earlier individuals, there are genetic tests that you can do now as part of your clinical care, and you should ask your doctors about those. But they've been developed through large programs like this. And so we have broad research goals with this program, including discovering new gene-disease relationships. I mentioned novel drug development, but the two areas that I'm just going to focus on for the last few minutes are looking to see what results can we find in the DNA samples that we have that are medically actionable and relevant to the patients that have enrolled in this project. And then how do we give that information back to them to translate findings into clinical care? And so far, we have actually sequenced about 20% of our patient population. So we have about a little over 200,000 patients that we have DNA sequence on. We use this information to look for changes in genes that we know are medically actionable if they have a change. So things like breast cancer or heart disease. And with these clues, what our hope is that we can either prevent these medical conditions altogether through increased screening or other changes to medical care, or at least it gives us the opportunity to diagnose them earlier and catch cancers when they're a much earlier stage, for example, rather than stage 3 or 4, where we know it's harder to treat them and go to remission. And we're also looking for new treatments or medications to manage these diseases better. And I will tell you, when I was going through my training, we never thought that we would be able to have drugs that actually can change a person's DNA and prevent them from getting a disease or make them recover more quickly. You heard Senator Blunt yesterday mention CRISPR, where it's actually like little scissors that can go in and correct DNA. It's incredible, the technologies that have been developed over the last several years that really do give us a different way to think about disease once we know the underlying genetic etiology. And so this scorecard just shows that we've consented over 345,000 patients into this program. We have, of course, have to get DNA sequences available to them, and then there are different criteria as part of our project for when people are eligible for review. But we hit a milestone in that we've now reported these types of medically actionable results back to over 5,000 of our Geisinger patients. And I'll just tell you another story related to that. So this is Jeff's story. He was a male in his 40s enrolled in MyCode, and he was found to have a change in the RET gene. This gene causes multiple endocrine neoplasia type 2. It's a type of cancer syndrome, and you often see thyroid cancer in these patients. Jeff had never had thyroid cancer before or evaluation for any issues, but we had him meet with some of our clinical teams. We had found a nodule on imaging that was shown to be benign on biopsy, but because of the known risk and the high risk for cancer, given this genetic change that he had, Jeff elected to go ahead with prophylactic thyroidectomy, so meaning he just took the thyroid out instead of waiting to see if anything would develop. And post-surgery pathology actually found that he had medullary thyroid microcarcinoma. So it wasn't appreciated on the biopsy, but when you were able to look more fully across the thyroid, we did find evidence of cancer. And because these are genetic causes, you have to think about cascade testing to different family members because we can pass these changes down through family members. And so Jeff did have multiple family members tested. And several of his children and I think some of his brothers were found to have the same change. And so Jeff's quote is on the right: "If it wasn't for MyCode, I would not have had the operation and they would not have found the cancer. Finding this so early on made the experience truly worthwhile." And we work really close with our clinical teams as part of our MyCode project. And this is Dr. Purdy on the right, who was Jeff's surgical oncologist, and saying that having that information really influenced his treatment decision. He felt like there was a high enough risk over Jeff's lifetime that doing that prophylactic surgery was warranted, and that he was able to give that information to his patient to make an informed decision. We've worked very closely with Dr. Purdy on cases like this, and his work and pulled together a group of patients with similar results as like Jeff's. And he was successful getting his work and the story of these patients published in JAMA Otolaryngology Head and Neck Surgery Journal. And I always like to point out that the first author on this paper was actually a resident working with Dr. Purdy. So one of our trainees was first author on this publication, putting together the stories of the patients who went through similar experiences to Jeff. So I mentioned that we've now reported over 5,000 results. And of course, as I just said, this cascades down to additional family members. So that number really blooms when you think about the number of family members that are also carrying these types of genetic changes. And we see things in cardiovascular diseases like familial hypercholesterolemia. So this is having high risk for high cholesterol, so that it has to be controlled by medications because the risk, because of how high the values are, diet and exercise aren't able to lower those to where they would be considered healthy. So you can see we've had over 580 results in that area. And this shows that patients have increased risk for these types of cardiovascular conditions, and often the recommendations are increased surveillance or interventions, as in the part of high cholesterol, we would put patients on statins and then monitor them more closely. Cancer is another big area where if we know early, there are often things we can do through increased surveillance, screenings, or risk reduction. Lynch syndrome is a cancer syndrome that has higher risk for breast cancer, ovarian cancer, pancreatic cancer. And certainly if you can stay ahead of that, you can hopefully prevent individuals from getting some of those types of cancer. Again, we've had more than 500 patients with results for that one particular syndrome, and we test for many more. And then there are things that are less common but still important. So malignant hypothermia is a condition where you're susceptible to having a bad reaction to a certain type of anesthesia. So knowing that before one goes into surgery certainly could be important to avoid those types of anesthesias or drugs. And we've had 225 of our patients that have changes in the gene that causes that particular condition that can then change how we approach care. This table is available online if anybody's interested in looking at all of the different diseases that we test for. The QR code is you're able to see the link on this, or you can honestly just Google Geisinger scorecard or Geisinger my code, and it tells you about the different types of conditions that we treat for and how many patients we've actually found and been able to give these results back to. And I mentioned this started out as a research study, but once we realized the vast number of patients that had these types of conditions, we realized that we needed to develop a better way to get this information back to patients, because you're not supposed to report results back from research because it's not, the samples, et cetera, aren't collected in a way that meets all the clinical guidelines. But we were able to change our research program to do the things in a manner that was consistent with clinical return of results. And so that's when we started this program to make sure that the patients who we knew this information about could have that information incorporated into their health care. And so what have we learned that has allowed us to provide better patient care to our families? So one is better ascertainment. So, a lot of people, like I said, there's testing available from your doctor today for many of these conditions, but you have to have the condition to ask for that testing. So you have to have had cancer, or you have to have had high cholesterol and know that you warrant that type of clinical genetic test. Unfortunately, for about 50% of patients, we don't know that. We haven't had that event happen yet that shows that we're at risk for this. So this type of population screening for these types of genetic changes really allows us to be more likely, in fact, 4 times more likely to identify diagnoses versus the standard of care where you wait for a person to get that disease or that clue that something is going on. It also has a behavioral impact. So we have found that once an individual knows that they have a genetic cause for the disease that they have, or if they know they're at risk for getting cancer or having heart issues, that more than 50% of patients change their behavior to try and reduce that risk. So either by taking a medication or having more frequent screenings, and we're hoping over time to increase that number. I mean, we all know everybody's not a good patient. We're never gonna get 100% of patients to listen to what your doctor tells you, but we have seen higher adherence to do the things that they're asked to do to take better care of themselves. And finally, as I mentioned, we're seeing that this leads to earlier diagnoses. So we're seeing cancer diagnoses at much earlier stages that are more localized before they've metastasized to other sites in the bodies when we do find cancer. And so that allows treatments to be a little bit more straightforward when you're treating a more localized region than something that's distant and spread throughout the body. I think one of the most impactful numbers that we've learned from this work is that most patients are unaware they have a genetic risk for disease. So in our patient population, 88%, so close to 90% of the patients were unaware that they had this genetic risk before we reported these results back to them. And you can see of the ones who did know this information, again, when you think about diseases you may have that you would present for healthcare, most were a cancer. So they've been doing genetic testing for individuals who have a diagnosis of cancer for many years now, followed by cardiology and then others. And really, the goal of this and our hope is that by identifying a genetic cause, we either are allowed to prevent disease altogether, identify it earlier, or treat it better. And by treat it better, now there are more and more therapies that are particularly really designed to target specific genetic changes. And the outcomes, you hope, because you're using more personalized or precision medicine, will result in better outcomes for those patients and families. So this is my last patient story. This is Kim, and she was a female in her 60s who was found to have Lynch syndrome. I mentioned Lynch syndrome is a cancer syndrome that can cause breast, ovarian, pancreatic, and other cancers, including colon as well. She had 2 adult children. They were both in her late 20s, and both were found to have that same genetic change. So now the children and Ruth all get yearly colonoscopies. They also follow up with other types of screening, and they're followed through our high-risk inherited cancer clinic. And the quote on the left is from Lynch saying, "The more you can be proactive than reactive to a situation, it's all worth it. My code allowed me and my family to be proactive." And this is just an example from a care pathway with information like this in hand. And again, thinking about high quality care and doing the same kind of treatment once you know this information. And on the left is what's done for an average person, an average population, when we all know, you're supposed to have your colonoscopy every 10 years starting at age 45. Well, in the case of individuals with Lynch syndrome, they need to have colonoscopies every 1 to 2 years, and we start that way earlier because we know that people are more likely to get cancer earlier in life, so around 20 to 25 years. And you can see there are other screenings also offered for gastric and small bowel cancer and pancreatic cancer. And so this has led us to sort of our 10 years of MyCode, taking a step back and seeing where have we come with this program. So we partnered with our industry partner. We now have 20% of our entire Geisinger patient population sequenced. We know that we have 1 in 30 patients that we find one of these actionable results. So you look around this room, 1 in 30. So it's not uncommon to have one of these genetic changes for a health condition. And then, as I said, when one person learns it, that information obviously is important to their family members. It's helped us to garner external funding. We've built new collaborations. We've been successful publishing and sharing our work with others so that they can also learn from our lessons. And then the potential for new therapeutics is really just the next stage of where we're moving with this work. And so that leads to thinking about the future. And as I said, in our case, we focused on genomics, and we started with a research project. And now we're having conversations about how do you work this into everyday routine healthcare. And there's lots of ways to do this across the span of how we take care of patients, whether it's like prevention, like I just described to you, also using pharmacogenomics. I'm sure a lot of people have heard about certain medications, and some people react well and some people don't. And so why don't we use that information instead of trying a bunch of different medications on an individual patient? There's a lot of exciting work being done around early risk for cancer detection. So from a simple blood test, one can see if you have a high risk for cancer based on just changes that they model. Basically, it's your genetics sort of chaotic, and they can measure this now from your genetic information, and then they have to go back and try to figure out which gene is causing that, but it's a way to see something is going on. They then do imaging by full body MRI to see where might that cancer be, and then they try to figure out and target the single gene that may be causing it. There's a lot of exciting work going on in that space now. And also just trying to follow that. So once you have cancer, people have to be tracked over time to look for evidence of recurrence. We do that now with imaging, which works okay, but we know there's better ways to do that. And now we're using, again, those blood tests to see how does your DNA look? Is it stable? Is it going a little chaotic again? Again, those early looks into how we take better care of patients. And so I'm just going to conclude by pointing out some of the topics I talked about today and how we think about leading and not following, and how you as a community have an opportunity to take advantage of the unique assets and strengths that you have. A community that's working together, that can strategically align goals across initiatives, thinking about innovative programs. I mean, the building yesterday, I'm so jealous of. I told Dr. Van Galen, if I was an undergrad and had access to that, there's no way I would not go into healthcare. But I think there's just innovative programs like that that can really leverage unique strengths, and then seeing and preparing for the future. So where is the next target of how we can take better care of patients, how we can train people better, and how we can do research that leads to the next generation discoveries. So I think there's a unique opportunity that's really exciting. Thinking about unique innovations to change the future of healthcare, leveraging unique expertise in opportunistic areas, again, uniting efforts to develop strategies that cross traditional boundaries, and coordinating those shared pathways to bring strengths together and make a bigger impact. So I think you have an exciting program that I'm excited to watch, and I hope that Joplin becomes a national model for others to follow. So I thank you for your attention, and I am happy to take questions.
Could you tell us more about the inherited risk clinic that was mentioned in one of the slides?
Sure. So once we identify an individual has a type of genetic change, we have specialized clinics that follow them a little bit closer. So that means we have some of the cancer docs or some of the cardiology docs that if we know what particular condition they're at risk for, they have a team that they meet with more frequently. And often, so just as an example, in the high-risk breast cancer clinic, traditionally a woman gets a mammogram every year. They get a mammogram once a year. They get an MRI once a year. So they're followed more closely, knowing with this genetic information in hand.
Kind of closely related, I know a lot of people are afraid to get genetic sequencing because if something does pop up, then their health insurance rates will skyrocket, and I wonder how you deal with this situation.
Yep. So there's a lot of, in fact, it was one of the questions I was going to ask Senator Blunt yesterday. There's a lot of work in that space. There's actually an act called GINA, which is the Genetic Insurance Non-Discrimination Act that is supposed to prevent people from that. But there's still a lot of work to be done in that space. So I know a lot of times our genetic counselors talk about that with people before they have genetic testing, but really there's been very little cases where insurance has changed based on genetic information. And quite honestly, I mean, if you look at some of the families who have positive genetic findings, if you just looked at their medical history, it's no different than what we know from genetics. A lot of insurers are actually starting to pay for genetic testing as part, well, clinically they pay for it, but also now people are thinking about population screening and population health, because to an insurer, if they can divide patients out by these patients we know are at high risk for developing some type of heart disease, and they can follow them more closely and keep them healthier, that's way less expensive from an insurance perspective than paying for disease once they get it. And so I think earlier, there were a lot of fears around that. I think there's still legislation that needs to be articulated a bit better, but I think it will become just part of routine healthcare.
You talked about exome testing. Is there any usage of epigenetic testing along with those things, or now or in the future?
So I couldn't hear your whole question.
You
testing.
talked about exome testing with this MyCode.
Yep.
Is there any utilization with epigenetics?
Oh, epigenetics.
Yeah.
Yeah, so exome is sequencing just the genes in a person's DNA. And epigenetics looks at modifications that are made through DNA through methylation or other changes in DNA sequence. That's a really active growing area, I would say. I don't think there's a few applications that are in clinical testing now with some of the diseases that we know have epigenetic factors. So, but it's not utilized as broadly yet, but it certainly is a growing area, I would say.
Yeah, I just want to touch back on your 65 Forward program. Mm-hmm. Who recruited the program? Like, how did you recruit for patients to be part of the program?
Yep. So right now, the way that program is set up is it's a partnership with our insurance plan. So thinking about value-based care and how you sort of build programs together to take better care of patients, increase quality and decrease cost. So the patients who can enroll in that program have to have one of our plans within Geisinger Health Plan. And anybody who has that plan is then eligible to participate. And so they self-enroll. I mean, certainly we tell people that are 65 and older that they're eligible to enroll in that program, but they really self-enroll in it through just learning about the program.
And as far as pricing, is that comparable to Medicare programs?
Yep, it's a Medicare program.
Okay.
Mm-hmm. Yeah, it's funny, the people who are in it whose friends do not have Geisinger insurance, they're like, why can't you let everybody who has Medicare into this program? We're like, well, that's the part of the program is we want it to be our health plan because that's where sort of the synergy hits from, you know, our health plan and our system working together to take better care of those patients. But it's been very well received. It's like a little party when you go into some of those clinics. And actually, it's one of our most successful recruitment sites for our MyCode project because often the individuals have grandchildren and they're thinking about their grandchildren's health. And they're like, you mean like if I enroll in this, it might be able to help my children or my grandchildren. And they're very engaged. They want to know results. They want to hear these stories. So our team actually goes to those sites pretty frequently because they just enjoy learning about it and hearing about genetics.
You talked about your student scholarships for primary care and psychiatric. So I know that psychiatric is part of your mission. Mm-hmm. What genetic research are you doing with regard to psychological treatments or different mental illnesses? Yeah. Is that something that's becoming more popular?
Yeah, no, that's certainly my research area. So I started, working on pediatric mental illness and mental health related to some of the conditions, developmental conditions like autism and intellectual disability, epilepsy. And I think I was just telling Dr. Van Galen yesterday that it kept expanding because what we learned about those genetic changes, now we know the same genes that cause autism can cause cerebral palsy. So they're all brain genes that manifest differently based on, of course, a number of factors. But then now that has expanded to adults. So what genes we know cause pediatric conditions, we now know can cause schizophrenia or bipolar disorder. They're linked to anxiety and depression. And so it allows us to think about those based on underlying genetic etiologies and how we might treat them as a group, and whether that's by shared genetic pathways. So, one gene or many genes in a pathway, maybe they're more responsive to a particular drug. Instead of not knowing that information and just treating every individual with depression with the same drug. There's been really exciting work in epilepsy that has started to show that if you know the genetic cause of a person's epilepsy or seizures, that there are drug therapies that work better. And so it used to be that in a child, for instance, who had epilepsy, you tried drug 1, drug 2, drug 3, And now what we're seeing is if you know a child with epilepsy has a change in one of the sodium channel genes, you start with drug 3. And you don't have to go 1, 2, 3 anymore. And so I think it's still, compared to like cancer and cardiology, still in its infancy, but definitely promising findings in that area.
You mentioned a cancer infusion in-home healthcare service support. What other unique in-home healthcare support services do you have?
I didn't hear the first part of your question. I heard the last part, what kind of support services?
Yeah, in-home healthcare. You mentioned cancer infusion support for those who have cancer.
Oh, for cancer and infusion.
So what other new?
Oh, so what else do they do at home?
Yeah.
They actually are doing a lot at home. So they're using a lot of digital technology to measure. So COVID is a great example. When people were sick with COVID, they tried to keep people at home instead of bringing them to the hospital. And they were using digital monitors for their temperature, for their oxygen levels. They had them on oxygen at home. So that was one, I think, you know, the pandemic was terrible, but there were certain things that came out of that. That was one sort of push for, wow, we can take better care of patients at home than bringing them into the hospital. So we do that for some of our cancer treatments. Individuals who have just had certain surgeries where, you know, once they're past a certain point of they really don't need to be in the hospital but need to be monitored, they'll move them home earlier than we would have traditionally. So it really spans the gamut of healthcare, and anywhere where they think that they will be safe to be at home with appropriate monitoring, we're trying to move that care to the home. And again, there's a lot of digital technology that goes into that, and getting patients set up with iPads and the monitors that, you know, are monitoring their heart or other measures, but it really spans a lot of various disease areas. All right, well, thank you all so much for your attention. Thank you. Oh, sure.
Thank you. So as Dr. Van Galen mentioned earlier, we feel like you're part of the Line family at this point because of all the interaction she's just been over the last weeks. We've been discussing Joplin and how we integrate together with what she's doing and the work she's doing. And so Dr. Van Galen, if you don't mind coming back up, we have a little presentation for you that he would like to share with you.
Thank you again, Dr. Martin, for being here. And we have a Missouri Southern gift bag with a few items I hope you'll enjoy. There's some Southern honey in here, which is made by our faculty and students. And
Oh, wow.
let's see here.
Oh, lovely.
We have a little piece of Southern swag that you can bring back
Nice.
to Pennsylvania. And,
I love it. You saved me a trip to the bookstore.
So thank you again, and let's give
thank you
Dr.
so
Martin
much.
a round of applause. Thank you.
Thank you very much. So sweet.
That's great.
Thank you. Can I take that?